Hello, everyone, and welcome to today's Schwartz Center webinar, Caring for Yourself and Others During the COVID-19 Pandemic, Managing Healthcare Workers' Stress. I'm Stephanie Adler-Yuan, Director of Education and Training here at the Schwartz Center for Compassionate Healthcare, and I'll be your moderator for today's session. We are so grateful that you're able to join us today, and we're profoundly moved, I have to say too, by the overwhelming response to this program. The Compassion in Action webinars are a program of the Schwartz Center for Compassionate Healthcare. We're a Boston-based nonprofit organization. We were established in 1995, and many of you I know are familiar with our flagship program, the Schwartz Rounds, which are offered in hundreds of our member organizations around the world and provide caregivers from all healthcare professions with a forum for discussing the complex emotional experiences of caregiving, which have never been more profound than they are today. So let's get started. Before we do, there are a few things we'd like to note about today's session. First of all, the Schwartz Center's Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. We're so grateful for that. Today's program is going to last for 60 minutes. So we'll have a presentation from our speaker for the first 45, and that'll be followed by a 10 to 15 minute question and answer session. Although all of you are in listen-only mode, we do encourage you to interact with our speakers using the questions pane on your GoToWebinar dashboard. We will have the slides available via the handouts module on your dashboard as well. And there are a few other wonderful materials there that have been provided by Dr. Watson today too, so take a look at those. I also want to add that we know that so many of our colleagues are unable to join us here today, and the program will be recorded and available on our website as of tomorrow for future viewing. Last but not least, as you exit the webinar, you will see a very brief survey that we ask you to complete so we can capture your assessment of the program. We read every single comment, and we appreciate your feedback. So now it is my absolute pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is Chief Medical Officer of the Schwartz Center for Compassionate Healthcare and an Associate Professor of Medicine at Harvard Medical School. Welcome, Beth.
Thank you, Stephanie, and good afternoon. Thank you all for joining us for today's Compassion and Action webinar. This is a challenging time for all of us, and here at the Schwartz Center, we are fully committed to supporting all healthcare workers in our efforts to sustain compassion for those who offer care and for those who receive care. And we're really, really pleased to be able to offer this webinar, which I know will leave you feeling empowered with new skills and strategies to help you help yourself and others, your teammates and colleagues. And I'm really delighted to introduce Patricia Watson. Dr. Watson has been a clinical psychologist at the National Center for PTSD since 1998. Prior to that, she was an active duty Navy psychologist for 8 years. She received her doctoral degree from Catholic University and postgrad fellowship in pediatric psychology at Harvard Medical School here in Boston. She's written a lot and widely about disaster mental health interventions, early interventions for traumatic stress, resilience, moral injury, military culture, among other things. And she's a co-author of the Combat Operational Stress First Aid for Navy and Marine Corps, multiple versions of stress first aid for firefighters and emergency services personnel, law enforcement professionals, wildland fighters, nurses, probation officers, rail workers, and so much more. I have turned to her as really a treasured and respected resource in my own work and research, and I'm just so pleased that she was able to be here with us today. Thank you, Patricia.
Thank you so much, Beth. I am very happy to be here, and I'd like to take just a moment for you all to maybe close your eyes and say a virtual greeting to the 2,000 people on the line today, because from what I understand, we're all over the world, and for me, it's a powerful experience to be able to share this time with all of you. So today, we're going to be talking about some of what we've learned about well-being in the context of disasters. And just to start it off, I wanted to make a note that in all the years that we've worked, we found that there are many lessons that have been learned over the years. If you look at the research, it typically is geared towards the effect of disasters rather than the impact of interventions. But we have tried over the years to bring together people in expert panels and to look at the research and to interview for lessons learned. And we found some key messages that I hope can be helpful today. It's always a bit challenging for me to give a webinar like this because typically when we're talking about the stress first aid model, it's a 1-day training, a 2-day training, and sometimes a 3-day training. So I'm going to do my best to give you the overview. And as you'll see in your handout, there are many, many slides that I will not have time to cover today, but I wanted you to have them as a reference. And we'll do the best we can to give an overview of the slides. So what I've learned in the years that we've been looking at this is that well-being in the context of disasters varies greatly, and that it's oftentimes in work settings, both a learning challenge and a leadership challenge. And when I say leadership challenge, it doesn't mean people that are typically in leadership, official leadership roles, but leadership for anybody in any position as to how they're going to turn to others and make a difference in others' lives. We also know that it requires us to make sense of and respond to ever-changing context. And I would say of all the disasters that I've had to be responsive to, this one more than others is ever-changing. And in that sense, creates a whole series of challenges for all of us. We also know that within the context of the work that you're going to be doing, that there are going to be times when you have to adaptively navigate and stay present and centered in conditions that are often fluid. I just want to make a note of the fact that my control is not advancing the slide at this point, so I might need to have a little bit of help with that. And lastly, we found that it really demands a willingness to experiment and remain creative, because in times like this, one of the most challenging things about giving a presentation like this for me is that it cannot be prescriptive. We cannot say to you, you need to do X, Y, and Z in order to have well-being. In situations like this, the context demands that people adapt any kind of stress management, any kind of support that they're giving to others. So it's a matter of almost like a dance where you're having to take a step forward, take a step back, and sometimes the dance has to be very quick and you only have a few minutes to support others or take care of yourself, sometimes seconds, and other times you'll have more time and more ability to do some of the things that we know are helpful for people. I'm quickly just putting this framework up here. It looks like it would be pronounced Cynefin, but it's actually a Welsh word that is pronounced Cynefin. And the reason I like this framework is it's an engineering framework for flow and flow dynamics. And I think about it often when I'm operating within disasters, because it discusses the difference between different frames that people operate within. And the simple frame is typical when we're in our typical day-to-day activities, business as usual. It's controllable, it's predictable. We usually look to best practice to answer questions for us. And the downside is that leaders can sometimes become complacent and we just do things like we've always done things. When we move into the realm of disasters, we find that the realm that we're in now is chaotic. It's about rapid response. And in that realm, what we find is that relationships between cause and effect are impossible to determine. We're going to have to progress again on this one. And any leaders must act to establish order, progress again. And so during this time frame, oftentimes the rules are very set in stone. You know, you have to do it this way, you have to do it that way. And it also is a time when innovation is required and is necessary. In the next realm, you move into a time when relationships between what's causing something and the effect is in constant flux. And this is a time when people have to try things out. Sometimes things work and sometimes they don't. But in that realm, when you're working in teams, it becomes more important to have good communication and get feedback from people as to how things are working on the ground. What's working, what's not. How are we best going to take care of each other? How are we not going to take care of each other? And there's a need to tolerate failure because things aren't going to work one day and will not work another day. And finally, when you have a little bit more time out, you move into the complicated realm, which oftentimes you can bring in experts. You can look at things a little bit more closely. You can ask people who have been through similar experiences to lend a hand and give you input. But sometimes decisions can take time when you're bringing in experts, and it's still necessary to welcome solutions from the people on the ground and to get a flow between what lessons learned from other experiences can bring to the situation and what is happening on the ground. So the reason I like this model is because what I see sometimes happening in disasters, and if we progress it one more time, is that organizations and systems can become disordered because they're not adapting to the phase. They're either trying to do things as they've always been done and not making decisions quickly enough. Well, this is the way we've always done it. Or they remain stuck in a realm and aren't moving from chaotic to complex to complicated. So they get stuck in modes that aren't as effective as they could be. I start with this because I want to emphasize the point that as we talk about the actions that may be helpful, as we talk about moving and progressing through an extended outbreak pandemic situation, things are going to change from one mode to the next, and the decisions that you make should be based on what's happening at that time. Okay, next slide. And this slide also has a lot of builds, so I will just say progress when we're ready to progress to the next one. We started to look at stress reactions that are specific to pandemics. And because of that, what you will find is that you're going to be dealing with a lot of potential stress reactions, anxiety about your health, about your well-being, about others' health and well-being. Next. And because of that anxiety, a sense of helplessness or a feeling of loss of control, maybe being exhausted and not able to function as you would like to have functioned or the way you used to function. Next. It may be that your confidence levels drop about whether you're able to function as well as you'd like to, or confidence about the systems that you're in, or the equipment that you're using, or the systems that you're affected by. Next slide. Next build. It's common to have anger when you perceive that others' actions put either yourself or others in harm's way. Next. We also see on the next progression that people have a tremendous amount of guilt in situations like this. Healthcare workers in particular often have guilt about fearing illness, guilt about the fact that they don't have the resources that would be helpful for people, guilt about fear that they or family members or friends might be faced with death or illness, or guilt that they're not able to do as much as they want to do, or they're not wanting to work or care for others because they have fears, maybe that they're not doing enough because they're not feeling empathy. Because what we've seen in extended situations like this is that that's a common occurrence, that people start to become numb. They're just dealing with too much. There's too much on their plate. And they start to feel guilty about not having the level of empathy that they typically have. And lastly, guilt about not coping as well as they want to or feel that they should. Next. And lastly, we see a lot of potential for grief and depression about lost lives or lost health, lost time with their family and friends, lost income or resources, lost abilities or beliefs or attitudes. Sometimes people feel that they're not able to enact and act upon the things that typically keep them strong in their role, lost connection or affection with family members or friends, and sometimes a grief and depression about lost plans that they've made that can now not occur. Okay, next. So within the realm of disaster support, I'm going to focus a lot on peer support, and I want to mention to you why that's important. What we've seen over the years is that most people that are injured by stress, we call it a stress injury, it can either be traumatic or loss or some sort of moral injury or fatigue injury, will tend to cope over time, but some will move into the zone of having diagnoses and become ill from their stress. However, what we've seen is that those that do become ill are not always likely to seek help. And many of you know that you've known people or you yourself have had times in your life where it might be helpful to talk to a counselor or a therapist or get more formal help from a clergy member or somebody like that. But we know from looking at the research that rates are low for seeking help, even when everything is set up to make it easy for people. Some of the research has suggested that people wait years, sometimes decades, to get the help they need after being exposed to high levels of stress. And yet, we also know that there's evidence to suggest that early management of stress reactions is effective. Sometimes 3 to 5 sessions can be effective for PTSD or other types of stress reactions. And it also stops a cycle of people spiraling downwards with other adaptations like substance use and that kind of thing. So, what we're aiming to do is get people the peer support they need as early as possible. And also hope that some of that peer support might help them get into more formal treatment if that's what they need. Next slide. So, with that as the context, we also know that it's hard to implement solutions for a lot of reasons. When you aim to give people guidance about peer support, there are things that need to be balanced. And what we find is that time and resources typically track with self-care and support. So when you have more time and more resources, you're going to have more self-care and support. On the other side of the scale is stress and burnout. And if you progress to the next slide, next click, you'll see that the dynamic is typically, I think you have to click it again, that one did not work on the webinar, but you'll typically see that resources and time track with peer support and self-care. When they go down, burnout and stress go up, and vice versa. When burnout and stress go down, it's usually because you have more time and resources, or you have the ability to do more self-care and more peer support. So where you are on that scale is very, very important in terms of how much you can do. And also, when we give our trainings, I'm also really well aware that there are lots of programs that go out there and say what you need to do is meditate regularly, or exercise regularly, or take care of your diet regularly, or do any number of things regularly, and you have to do them for 20 minutes a day or this or that. And yet when you 500 people on the line, there are going to be some people who say that's not my thing. I'm not a meditator. I'm an action person. I'm a problem solver, or vice versa. I have my own style. So what we've tried to do with the work that we've done is to try to offer a menu of possibilities for people. Next slide. And within that menu of possibilities, we're also very well aware that that menu should be used as needed by people when and if they can enact those core actions. So we developed the stress first aid model at the request of Navy and Marine Corps at a time when they wanted a model that could be geared mostly in the military towards peer support. When we transferred it over to fire and EMS and other settings, they wanted it to also include self-care. But within the military, they were really well aware that people were getting lots of stress management courses and being told how to be resilient. And yet, with the level of stress that they were under and the number of deployments that many of them were in, it was inevitable that everyone was going to have some vulnerability to the stress they were experiencing. So they wanted a model that acknowledged that when that stress is high, that people could turn to each other and provide support to each other. No matter how much stress management they knew, they were forgetting everything they learned at certain points. And that's the point where it's good to have somebody next to you who can remind you and say, I'm here for you. What do we need to do? How do we need to help you? And so this model includes 7 actions that we hope can help identify and address stress reactions, hopefully early. If not, that's okay. Address them at any time that it's needed, both in yourself and others in an ongoing way, not just after critical incidents, but after any kind of stress. Next slide. So as Beth mentioned, the model progressed from being a military model to going into fire and EMS. We also, in fire and EMS, adapted a model for public-facing stress first aid, which I think we're going to attempt to have a webinar about in the future. And as Beth said, it also has been adapted to different populations. Next slide. Within that frame, one of the things that we've been aware of within all of the populations that we've worked with is that most of the people that are in settings like this, who are in settings where they might potentially have high levels of stress, are typically guided by ideals. They're guided by values and ideals that guide their entry into that job and that guide their daily decisions and their choices that they make. Those ideals are things like click, selflessness, and placing the welfare of others above your own. And that strength and that job that you're in allows you to enact these ideals on a daily basis. I mean, it becomes stronger with these ideals because you're in a job that helps you to practice these ideals regularly. So you can be selfless, you can be loyal, and have a commitment to accomplishing missions and protecting others. Next one is you can be a person who is who has stoicism and become stronger with your ability to endure hardships without complaint. You can live by a moral code that allows you to have an internal moral compass and choose right over wrong. And you can live by a value of excellence where you're always trying to get better at what you're doing and to be the most effective professional possible. What we also have seen, though, is that this is a double-edged sword, because whenever I give a training, I ask the audience, how many of you have not made a medical appointment for yourself that maybe you needed months ago? And I usually get a third to a half of the audience raising their hand because they typically are putting other people's welfare above their own. We also have found that in the realm of loyalty, you are more likely to be a person who then becomes guilty or has complicated bereavement reactions after the loss of others. When you're stoic, you're oftentimes not aware of, or you're not acknowledging, you're not even paying attention to symptoms that you might be having. You might even become numb and not feel things that you used to feel. When you have a moral code, it's typical in the populations that I've worked with that they tend to get frustrated with others who are not as service oriented as they are. They go to other places, to stores and restaurants, and they get frustrated with people who aren't trying to be of service. And the downside of that is that you tend to shrink your available pool of social support because you don't feel that other people understand who you are and what you consider stressful versus what other people tend to consider stressful. And lastly, in the realm of excellence, there's a tendency or a vulnerability towards feeling ashamed or trying to minimize your own imperfections, and as a result, not talking with people about things that are troubling you or things that you might need. Okay, next slide. So we have seen, because of some of these values and ideals, that there are obstacles that people have towards self-care. And some of them are attitudinal like this. How many of you have experienced this in yourself or others that you've worked with? It would be selfish to take a break from work. Others are working hard, so should I. I'm okay, I'm fine, I'm not even tired. And what we've seen with this is when we've interviewed people who have been involved in long-term responses to disasters, we asked them to tell us, what message would you want us to give to others who are involved in disasters? Almost all of them said, please tell people that they need to take care of themselves because the adrenaline will kick in and they'll think they're fine, sometimes for long periods of time. But when the adrenaline starts to be depleted, then they realize how utterly exhausted they are and that they have pushed their body probably beyond what they should have. However, on the flip side, we then asked people, well, now that you've been involved in disasters yourself, Do you feel better capable if you were in another disaster to take better care of yourself? And most of them said absolutely not. So it's a kind of a conundrum there. So we said to them, that's a bit of a mixed message. And most of them said, okay. When they thought about it, they said, you need to tell people to take care of each other because they will not take care of themselves because of all of these obstacles, all these things that people say to themselves. What happens is that when the need of others is great, all of these thoughts go through their mind and they become focused on others even more than normal. Next slide. And so what then you tend to see is that those thoughts get translated into behaviors, and the behaviors are things like working too long by yourself without checking in with others, keeping your stress to yourself, telling everyone I'm fine, I'm fine, I'm fine. Sometimes inflexibly concentrating only on what to do next without taking breaks to just recharge and rejuvenate yourself. And sometimes relying only on things like alcohol and substances to relax. I am not a person who judges that. I see the need for it in people. I see why people would turn to that, but I also have seen over time the negative downside to that when people are using that as their only source of relaxation. So these are things that can really create obstacles for people and get in the way of self-care. Next slide. I want to just mention briefly too that when we came into creating this model for military, one of the dynamics in the military is this concept of being a force multiplier. And the official definition is a force multiplication is the effect that's produced by a capability that somebody brings into a situation. When you add it to a combat force, it significantly increases the combat potential of that force and it enhances the probability of mission accomplishment. However, this idea of being a force multiplier has been taken out of military and brought into many different contexts in organizations. And it basically means that you have the ability as a person to multiply the impact on the effectiveness of an organization, but also on the effectiveness of each and every other staff member or coworker by focusing on who you can influence, how you can influence things, and what you can do to make change, what you can control in the moment, in every single step along the way. And we know that when people are focusing on how can I bring my unique capabilities into this context, that teams tend to work better because the collective effort multiplies results. And especially in times of stress, this means turning to others around you, not just your values of serving the public and serving patients, but also how can I serve the people around me so that as a team and as an organization, we have longevity. We need to have longevity because if we're not taking care of each other, we are not going to be able to take care of others, as many of you have heard, I'm sure, in other settings. We know from looking at the literature on burnout that the overall effectiveness of a group is going to be increased by respecting that everyone's going to have their own way to take care of themselves. Everyone's going to have their own way to get rejuvenated and to feel better. Everyone also is going to benefit from recognition. People around them just not overly praising people, but finding simple ways to let people know that what they're doing is making a difference. And also seeking out opportunities to reframe things, to find ways to not be a Pollyanna and try to make everything cheerful and happy, but to help people shift the way they're looking at something in that moment to help them take the next step to endure. So our model, next slide, is based on these types of principles. And in the next slide, I want to mention, and you can build out this entire slide, it's fine, that when we came into the military, we were dealing with a military that already said one of the things that we want to do is acknowledge that a lot of the models of stress management focus on traumatic stress. When there's a life threat, you have an exposure to things that are potentially traumatic in yourself or others. But they were really well aware that people were also reacting to loss. They were reacting to the loss of their coworkers. They were reacting to the loss of function and the loss of health and the loss of values. They were reacting to moral injuries where they they witnessed or had to engage in behaviors that violated or went against their own moral values. They were also reacting to the cumulative stress of multiple deployments, multiple long hours, long shifts, and the wear and tear of that. So this was something that they were committed to building into any model of peer support and self-care, that we had to acknowledge that all of these types of stressors were going to have an effect on people, both in the moment and over time. Next slide. So we started with, and this model had already been developed when we came in with our stress first aid model, with what the military and the Marine Corps called the stress continuum model. The goal of this model in a nutshell is to reduce stigma, to change the culture's way of looking at stress. And the idea was, what was happening at the time before this model was brought forward was that people were feeling that they had to either be in the green zone, which is good to go, I'm optimally functioning, I'm at my best, or if they weren't in that green zone, it meant that something was wrong with them and they were ill, or they were weak in one way or another. And because of that, people were hiding it and they were keeping it to themselves and they didn't want to talk about it. And so by bringing this model forward, the organization wanted to say, look, this is the reality of what all of us are experiencing on a daily and weekly, monthly, yearly basis. We are cycling in and out of these zones. We are moving from green to yellow regularly. And in many of the trainings that we've given, we've had people raise their hand and say, can we just acknowledge that yellow is the new green? None of us is in the green zone anymore. We're always in yellow, orange, or red. So depending on where your organization is, that might be the case. But yellow is typically transient distress, things that come and go. And they can be caused by any stressor. Boredom is one of those stressors. Sometimes when people are too bored, they get stressed. The features are multiple. There's any number of stress reactions people can have. This is just a sampling here. People get more irritable. They lose motivation and focus. They have trouble sleeping. They're not having fun anymore. But these things tend to come and go. When you move into the orange zone, you're typically seeing that people are being faced with these 4 causes of stress injury. They've either had too much wear and tear, or they're faced now with more pertinent or more in the moment or more severe or extended life threat loss or moral injury. And what we see as a primary feature in this is that people start to feel like they're no longer themselves, or they have less control over their reactions. Their reactions are more intense. They start to feel stronger feelings. They start to make more mistakes. They start to have misconduct when in the past that wasn't a part of who they were. And so the orange zone is where we typically say, this is where you particularly want to start thinking about stress first aid and turning to others, or taking better care of yourself, being more disciplined, being more balanced about some of these things. Most people in the healthcare field know about stress management. I don't think that I need to teach you stress management, but I would want to make the point that in situations like the ones you're in right now, it has to be brought up the list of priorities. So whatever it is for each person, it needs to be brought up a little bit in order to balance out the extended long-term nature of what's going on right now. What we're trying to do is keep people from moving into the red zone. And the definition of the red zone is more of the typical medical disorder. But all of us know that that line between orange and red is also somewhat subjective. There are diagnostic criteria that have to be met that are usually based on a persistent picture of symptoms and a more distressing picture of symptoms. But we all know that we've worked alongside people who have PTSD, who have depression, who have anxiety disorders, might be even using substances, and yet they're functioning. But what we're trying to do, and we see people cycling back and forth between having more persistent symptoms and coming back. What we're trying to do with our model is move people to the left, move people from wherever they are to the left at any given moment. Next slide. And with that, I just want to mention that within your slide set, I added as examples, what moral injury might look like in a pandemic situation, because what I'm looking at, what I'm reading in some of the publications that have already been published, is that this is something that people are concerned about right now in healthcare settings in particular, that there's a high probability that you might be faced with moral dilemmas in your job for lots of different reasons. So we will not be able to go through all of these slides in the time that we have, but I do want to make reference to the fact that we have them built into this slide set for you as a reference to take a look at, because we're concerned about this as something that you will be facing in the days, weeks, and months ahead. Next slide. So our model, when we first came in and developed the stress first aid model, we based it on some work that we had done with an expert panel, where we brought about 50 people together from around the world and had them look at the research on ongoing threat situations. And we talked about it for a day, and we talked about, okay, how do we guide people who are in ongoing threat situations about ways that they can get through these situations. What we found after having these conversations and looking at the research is that there are 5 elements or human needs that seem to be related to people getting through situations of ongoing threat. And these elements are improving a person's sense of safety or improving a population's sense of safety. When you see that happening, both in a public health setting and in an individual setting, people tend to get through and recover in a better way than when you don't take that step to help them feel more safe. Next is calming. This is something you see in almost every treatment protocol for PTSD and anxiety and depression. You also see it in public health messages. You see it in large-scale events. If you can calm people, if you can help people to get to a more calm place, particularly safety and calming have biological implications that help people to sleep, make decisions better, function better, and just feel better. We also know that social support and connectedness comes up again and again and again in the literature as a factor, an element that helps people to deal with and recover from ongoing threat situations, disasters, multiple different types of adverse events. Next is self-efficacy. This is a bit of a fancy term that means people feel that they can get through a situation. They feel they have the capacity or the resources to be able to navigate through a situation. And again, this comes strongly in the literature with disasters, that when people have this sense of coping self-efficacy or community self-efficacy, they tend to do better. And lastly is the idea of hope. When people have a sense of hope, they also tend to recover better. And hope is a broad term. It can mean a natural optimism. It can mean a sense that the resources are there for an organization or a community or a person. It can be a connection with a sense of faith or religion or a connection to something greater than oneself. It really is a broad term, and we put it all together as hope. But it does also show in the literature to be related to better recovery. Now, what I found from looking at the literature and working with teams is that people or teams do not have to have all 5 of these things. They can have one very strongly or a few very strongly, or they can cycle. Circumstances. But I think if you remember nothing from this webinar other than these 5 elements, you can use them and you can turn to them in many different ways to guide how to respond to your own needs and the needs of others around you. Okay, next slide. When we went to develop the stress first aid model, what we did was to take these 5 elements and map them onto a model that would be a longitudinal peer support model. And we knew that we were working with the Navy, so we wanted it to be something that people could remember. So we changed those 5 elements words to all starting with the letter C, because it's now the 7 C's of stress first aid, which is a nautical kind of reference. But we added in checking and coordinating because we knew that people would need to continually check in and assess, observe, listen to others over time, to have that be something that's happening all the time in an ongoing way, in small little ways that we ask people, how you doing? What's happening? Something I can do to help? Where are you? What's on your plate today? We do this all the time. What I hope as I start to talk about this model is that many of you on this call are validated by the things that you're already doing, because we have based this model as we've developed it out in different populations on what we've seen good leaders and good peer supporters doing on a regular basis. Those of you that are good at peer support or self-care are doing all of these things. And I hope this gives you a framework to remind yourself and to validate that these things are important. In a longitudinal way, they lead to better recovery in yourselves and others. So it's important to check on people regularly. It's also important to coordinate. This is a, first aid in many ways. It may be that people do need more intensive care, different types of care. So you should always be thinking, what help do I need? Who else needs to be involved? Who do I need to turn to if this person needs more than what I can offer? And then you work your way through. It's not linear. This kind of looks like it's linear. It's not linear. But you work your way through the 5 elements and you try to ask yourself, what does this person need? So I'm going to move to the next slide. The model ends up looking a little bit more like the next slide, where you're trying to get people to wellness, but it looks more like this. And this is a build slide too. You're checking in, you're approaching that person, and you're deciding what's needed based on their stress reactions in a lot of ways. Their stress reactions will vary. This is just a sampling. And then you may say, you know what they need is to be calmed. They're having anxiety. I'm going to try to help them figure out a way to be calm. I also need to help them feel more safe. So I'm going to try to cover them. And they may need to learn some skills to help them be more competent, to help them feel like they have self-efficacy and to get through it. So I'm going to do all 3 of those. But if you have time, if the person has lots of different stress reactions, it can look complicated because you're trying to decide, do they need to have skills, which is competence? Do they need to feel hope, which is we've called confidence now? Do they need to be connected to social support? You can pick and choose whatever you think would be helpful for that person and whatever they think would be helpful for them. Next slide. And so the characteristics of stress first aid is that it's flexible. You're trying to use very small steps, especially in situations where you're all overwhelmed. You're not trying to do a tremendous amount at each and every time, but you're trying to emphasize taking very small steps. The context and the timing are really important. What you can accomplish one day with your actions might be very, very different than what you could do another day. We really highlight also mentoring and problem solving. We know that when people are under stress, they tend to be less able to make decisions, to be creative, and to make decisive action. So just having somebody sit down with them and say, why don't we brainstorm together? Let me connect you with somebody who's been through what you're going through right now. Maybe they can mentor you a little bit. And it's not meant to address a full range of, mental health issues, but it's meant to bring people, as I said, from the right side of that stress continuum over to the left to help them get more into the yellow and green if you can. And if not, then you try to bridge them to higher care. And hopefully what you're doing is being a bridge earlier than what they would be able to do on their own, trying to get them into other care sooner than they would be able to do it for themselves. So next slide. So the essential skills for stress first aid, as we see it, are to stress is stressed or going through stress, particularly when they're in the orange to red zone, to act on it. If you see something, say something to the person. Or maybe you're not the one who should be talking to them. Maybe you see things, but you know that they wouldn't trust you or they don't know you well enough. So maybe you go and talk to a coworker of theirs who they are closer to. And then to try to build trusted resources that you could offer to a person if they're in distress or they're showing signs of being highly stressed. And to be the person who could guide them and lead them to resources in a way that they would be more likely to uptake those resources because somebody's telling them, hey, I know these, I know that this person would be a good person for you to talk to. And it gives them more of a sense of it not being a mystery for them. Okay, so I'm just going to show a couple more slides and then we'll break for questions. I want to let you know that you can build through this. You can build through this slide all the way and click through it and then move to the next slide. For each of the core actions of stress first aid, in your PDF that you'll have of all these slides, we have examples of what we think each one of these core actions could look like. And you can build through this slide as well. But what I want to say to you, rather than going into all of the core actions because we don't have time, I just want to mention that the reason why peer support is particularly important in the pandemic type of setting is that we know that healthcare workers are dedicated. The vast majority, and I don't generalize that everybody is this way, but the vast majority of them came to this job because of a sense of wanting to serve others. And we also know that when people get into the orange and red zones, they often are the last ones to recognize it. They often have stigma where they aren't going to reach out and ask for help. We also know that in extended disaster crisis settings like this, that people's stress zones are going to change from day to day, not just based on what's going on at work, but what's going on at home as well. So you may not be aware of a person's home life stress, but in the stress first aid model, all stressors are open for discussion or open to be considered as part of a person's total cumulative stress. So you may see somebody that's functioning very well on the job for weeks at a time, and then all of a sudden their functioning drops off, and you're wondering, well, nothing has changed at work. What you don't know is that they're going through some tremendous stressor at home. So our job is to just pay attention, be aware, and know that stress injury can last for a long time. It doesn't just drop off when the pandemic ends, quote unquote. It may be there in many different forms for months, sometimes years after a long-term intensive situation. So checking is important over time for long periods of time. I want you to just be aware that within our materials, on the next slide, we have a model that we developed for one-to-one contact with people that we call Oscar, and you can build through this slide as well. And it's just basically observing over time so that you can come to a person, and when you ask them how they're doing and they say fine, you can say, I know you say you're fine, but I've been watching you a little bit and I see that you've been more quiet, or you've been more irritable, or you haven't been laughing as much. I'm only saying this because I'm your coworker, but I also care about you. And am I right or am I wrong? And then you let them respond, and the two of you together can decide what needs to happen next. The next slide has simple questions that you can, as a team leader or a manager or even just a peer leader, can ask people from time to time. Let's talk about the things that you're concerned about right now, or you can do this after the fact and say, what were the things that were the worst for you? What are your greatest rewards and successes for this job, or what have been your greatest rewards and successes? And what does it mean to be in a unit like this? This can guide group conversations. It can get people to talk about things in a way that keeps them in the present moment in a lot of ways. The next slide also has questions that we've based on the 5 stress first aid actions that you can use to guide conversations you have with people, either one-on-one or in groups. The way that this is different from some other models of stress intervention is that it's really focused on the present. What's happening right now? How is this affecting your sense of safety, your ability to stay calm, your interrelationships with others, and how you're connecting with others, how you're able to handle things right now, and whether you have, noticed changes in your confidence. And so we built these into the model as potential tools for you to at least get started with thinking about what people might need from moment to moment, or week to week, or month to month. So with that, I'm going to stop so we have some time for questions, but just to let you know that you have the rest of the slides that unpack each one of these core actions a little bit, give some examples. There are strategy slides that we've gathered from people in many different settings that they have found to be helpful as ways to enact some of these core actions. And I know that we're also planning to have a webinar on April 7th that talks a little bit more about this model in terms of leadership in different settings. So we'll have more time to unpack it a little bit then as well. So with that, I would like to thank you all for your attention and turn it over to our moderator for chat and discussions.
Thank you so much, Patricia. I'm going to jump in here. We've had a lot of questions from people watching. This has been so helpful. It's such a practical, on-the-ground guide for reaching out to others and for helping ourselves. So I'm going to pose to you some of the questions that we received, and there are many, many. We won't have time to answer all of them, I don't think, but we'll, again, as Patricia has said, we're going to have additional webinars that will expose you to this kind of model, which I find very, very, very helpful. So some folks have asked about how best to advocate for themselves, especially with managers, supervisors, and leaders to, as you say, elevate the priority of stress management now. How can they interact with their leaders and managers and supervisors so they can become more aware of the experiences of the healthcare staff?
That's an excellent question. And one of the reasons why I included the Continuum model at the beginning, some of you may have been wondering, like, why is she putting this at the beginning? This Continuum model of organizational flow dynamics in disaster settings comes back to me again and again and again when I give trainings, which is that oftentimes leaders are stuck in kind of a simple mode of our priorities are patients and our priorities are doing things based on best practice, business as usual. They have not moved yet into the disaster realm where the priority should also be on staff and preserving staff in order to be able to do the job that you're all there to do. So we know from looking at disaster literature that if staff is not preserved, then ultimately your patients will not be cared for in the best possible way. So in the same way that you're attending to equipment and resources, staff need to be considered a resource that is preserved over time. And so, as I said when I was talking about that slide, one of the hallmarks of that phase is that leaders, managers, need to be getting feedback more frequently from their staff at a time like this. They need to be checking in, and it might be that you need to have natural leaders within the staff. And this is when this can happen. These natural leaders tend to arise during crisis situations where they have the skill set, because it is a social skill set to be able to go to a leader and be assertive and say, look, we need some attention. And not everybody's going to be able to do that, particularly when they're under a lot of stress. So if you have people, it does help for coworkers to reach out to each other first, to band together. This idea of unions, I think, arose from this, but this idea of banding together informally to say, look, we need to talk about the things that are most troubling for us and distressing for us right now. We need to find either a way for all of us or a way for one representative or a few representatives to carry this information up the chain to leaders. And sometimes it has to do with learning the language of that leader. If their language is about, unfortunately, there are some systems where the language of leaders is more about finance and or capital that way, then maybe that needs to be brought up the chain, that when you lose somebody who's well trained to stress, they drop out or they're absent in one way or another, you've lost a tremendous amount of financial capital as well, because having to retrain and have somebody else come on board is also something that is very, very costly and time consuming. So just in whatever language they can hear it, that's something that needs to happen. And the idea is that you need to orient them to the current context and contrast it with the prior context in a way that they can hear. And each leader, I wish I could give you a more prescriptive way to do that, but each leader is going to be different. Each team is going to be different in the way that they can do that.
That is so helpful. And I do want to remind everybody to tune into the next webinar that you'll be doing with one of your colleagues, Richard Westphal, on helping leaders and managers support their teams. So please do recommend that webinar to your your colleagues who are in those kinds of positions. So referring back to the,
I would just add to that comment that Richard Westphal is one of the co-authors of the Stress First Aid, the original model within the Navy Marine Corps. He's a PhD nurse who has been in very high leadership positions, both within the military and now in the setting that he's in. And he is an excellent presenter and has a lot of experience with how he has applied this model in a leadership type of way. So I think it would be, it'll be a great webinar.
Fantastic. So that's incredibly helpful. Thanks, Patricia. Let me ask you another one. I know people are wondering about how to apply stress first aid when face-to-face contact is so limited in clinical settings. And there may not be any answer for that immediately, but what are your thoughts about that? It is an issue.
Yes, it really is an issue. And I would say two things. In many ways, this situation, you've heard this word, I'm sure everywhere, all over the world, is unprecedented. Okay, so with things that are unprecedented come great creativity. And so I'm sure many of you have seen the way that people have reached out on social media. People have reached out to try to form Zoom work groups, Zoom being an online platform. It doesn't have to be Zoom, but any kind of online platform where people can speak like this together as a group. What people like about Zoom is that you can see each person's face, so that makes it nice. But there are other platforms like that as well. I would say that from my experience, it's not about, it is about how a bit, but it's also about the motivation to just make it a priority, to try to make it a priority to find ways to reach out via text, phone, video conferencing, whatever it is. And if you don't have technology, I've seen people be creative in other ways. Sometimes people find ways to be in the same room, but not close enough to be of a problem. And again, we know so little about what that means in terms of close enough versus not close enough. But I would just highlight this idea of trying to be creative and finding whatever way will work best for you, because it is important. The priority should be on social support and taking care of each other. It really, really has shown over and over again that it is important. Now, I know that very many of you on this call are introverts. And so it doesn't mean that you have to reach out to 100 people. It just means that you reach out regularly to the few, those of us who are introverts. I myself also in many ways am. We reach out to the ones in a more disciplined way, just saying, okay, I have to remember to do this, however that means for you.
Mm-hmm. Gosh, it's such great advice, and it sounds so simple, and yet there are so many impediments somehow. But these are things that we have to learn, because we can't take care of others if we are not taking care of ourselves and each other. There are so many wonderful questions that remain, but I am afraid that we're going to have to close out the webinar. I do invite everybody to attend the next webinar that we're going to offer on April 7th. Some of this model will be discussed again, and we will post the PDF of the webinar on our website.
I would like to offer that. I would also like to offer that we can attempt to answer these questions and find a way to disseminate our answers to your questions, either on the website or via some other mechanism. Maybe what we can do is answer them and have them posted as a file in our next webinar as well. But we'll make every effort to answer your questions. Yeah,
that'd be fantastic. Thanks so much, Patricia. So let me just turn this back over to Stephanie at this point to close us out.
Thanks so much, Beth. And thank you so much, Patricia. I have never seen a response to a presentation like this one, and everyone was really blown away. There are notes about people feeling less alone in the questions pane, and I'm just so grateful that we were able to share this presentation today, so thank you for that. So to everyone out there, I know many of you have been asking about the recording and the slides. You can download some handouts from the handouts pane on your GoToWebinar dashboard now, but I understand that the PDF of the slides didn't accommodate the animation, so we will be posting that again tomorrow on our website with a recording, which we do encourage you to share as widely as you like. We will be, if we could get to the next slide, we will be holding another Compassion in Action webinar, Leading with Compassion, supporting the hardiness of healthcare workers in a crisis, really focusing on answering those questions about what healthcare leaders could do with Dr. Richard Westphal and Dr. Patricia Watson. And so we hope you'll save the date. Registration will open for that on our website tomorrow. And we will, of course, be sending all of you invitations as well. And that's it. I'll bring it to a close. There will be a brief survey to capture your feedback on the way out. If you can take 20 seconds to fill it out, we'd appreciate it. We would love to know what else we can do for all of you. So if you have ideas for future webinars or requests, please send them our way. We will read all of your feedback. Until then, if you'd like to learn more about the Schwartz Center, please do follow us on social media and visit our website. If we could just go to the next slide, I want to thank everyone for joining us here today. And please, everyone, be well. We are so grateful for everything that you do. Have a fantastic day.